You are a Jason Bourne in the medical industry. So when you do this amazing job, you save multiple lives. That why that federal agencies and the business was behind you.
And what the business side of medicine has done, the insurance companies and the hospitals, is they've taken control of medicine to a point where doctors no longer have the authority to make the final call. Because the profit in medicine is on the business side, not on the medical side. On the medical side, it's about 8% of the profit. 92% of the profit is on the business side. And so doctors are stuck in this arrangement where they don't have the power, they don't have the control. And if you look at the number of doctors employed now, it's 80%. 80% of doctors are employed by a hospital.
So why that people are paying insurance so much, okay, but still they are paying out of pocket so much of money? Do you feel that government and the insurance companies are running that business?
Well, I think there's definitely some government, there's government involvement for sure. Everybody should have insurance. All right, I agree. But where's the money come from? If you raise the premiums, these are real numbers. Some of the insurance companies have made 1,700% more, 1,700% more than they did before the Affordable Care Act. Doctors aren't the problem. Doctors' income's going down, it's not going up. It's not the doctors that are costing Americans more money, it's the system. And the system has to be revamped completely.
So if a patient doesn't have any insurance, will the Mayo Clinic will treat them? You know what AI is saying about you? That you are a Jason Bourne in the medical industry.
Oh, really? That's pretty funny.
Yeah, that's why I was
going to just say that it's pretty interesting. I don't read that much about what people say, to be honest, for obvious reasons, to preserve my sanity, but that's funny that people would say that they would say that on AI.
Yeah, exactly. So that's why I was really excited. Okay, so let me start with some past backgrounds. Okay.
Sure.
So you were in the Iraq, right? In the heavy combat. So what's the hardest spine reconstruction you did in the war zone?
Well, I think the hardest reconstruction I did was every spine procedure I did in Iraq.
Okay.
Was challenging because the injuries aren't like the injuries we see in America. When we have, even at a level 1 trauma center, which is where I worked when I was at the Mayo Clinic and also when I was in the military, I worked out of a level 1 trauma center. I was at the biggest hospitals in the country at the time. And even those traumas don't compare to the trauma you see in a war zone, because almost all of the injuries we saw when I was deployed to Iraq, I was deployed twice, but when we were there, almost all of the injuries we saw were bomb accidents, bomb injuries. They were almost all IEDs. And so those improvisational bombs were laced with diesel fuel and bolts and screws. And of course, in the desert, there's dirt and there's bacteria in the dirt. And so the injuries were pretty horrendous. Nothing you can really even describe or compare to what we see in a normal trauma center in the country. So those challenges, when you have a patient with an open wound, with a bomb injury, and there's shrapnel and bolts and dirt and everything embedded in the tissue, it makes every surgery we do challenging, whether it's on the arms or legs or the body, the head, or in my case, the spine. And when I was deployed as a surgeon, an orthopedic surgeon, which is my foundation, and then my specialty is spine. So when you're there, you're both an orthopedic surgeon on the extremities, and you're also the specialist when it comes to spine. And so I had to do both. I had to do a lot of extremity surgery, and I had to do a lot of spine surgery because I was really the only spine surgeon there. And I would say all of those were challenging because when we do an operation in that scenario, the primary goal is to remove the tissue that's been traumatized, that's been damaged, and to get down to healthy tissue and to stabilize the bony structure. And of course, number one, to stop the bleed. And so when we're going into a spine trauma like that, the goal is to clear up the tissue. You can't do it like we normally do. In a typical fracture of the spine, injury of the spine, we make an incision, we go down, we put our screws in, we put our bone in, we get it to fuse, right? But in this scenario, you can't do your surgery immediately a lot of times, because if you do, it's going to fail from infection. The wound's
Right.
going to break open, the screws are going to come out, everything's going to fail miserably. So the primary goal is to stabilize their life, and then secondarily, to try to stabilize the spinal architecture. And sometimes we couldn't put the screws in immediately or put the rods in immediately. And so when we're doing orthopedic surgery on the extremity and on the spine, the goal is to get rid of all the infection first and then come back in multiple stages of washouts and cleaning of tissue, and then eventually perform more at least temporary stabilization. When we're deployed, our goal isn't to perform the final operation. Our goal is to stabilize that patient's bony architecture. First, again, always the life and then the bony architecture, clean up the tissue and prevent it from getting grossly infected, and then
Mm.
send them ahead to another hospital. And usually we would send them to Landstuhl in Germany. And in that theater hospital, there's a little bit more of a clean scenario, a typical hospital scenario where you can do the definitive fixation. And then a lot of those patients would come back to the States. They'd go to either Walter Reed or they'd go to Wilford Hall, and then they would do the final procedure there. So it was a multi-stage process. But those bomb injuries, I would say, were devastating. And we
Mm.
would see things that look like only what you see in a movie there, and we would try to get that tissue back down to normal. A lot of amputations, a lot of external fixations, a lot of wound vacs, which are basically a sponge, basically a genius invention that helps prevent heavy infection. And if you've ever had an operation, or if you've ever seen anyone with an operation that got infected, we'll even use that here locally in the States. We use just a much more mild version of a small strip and small triangles or small ellipses to help get the tissue clean. But we did those on almost everyone because we were trying to prevent the infections from getting.
So why the government has selected you? Because of that mindset, or that you have trained for it?
Well, when the way that it works for all doctors in the military is when you're getting into medical school, you can go several routes, right? If you want to go
Mm.
into medical school through the military, you can actually apply to the military medical school. There's one in Bethesda,
Okay.
Maryland, called
Mm.
Uniformed Services University of the Health Sciences. We call it USUS or USUS. And that's literally a training when you're active duty in the military. And so it's a multi-branch medical school. People from the Army, the Navy, the Air Force all go there to become doctors. And when you get out, you have a certain time commitment that you have to give back to your branch of the service. But you can also go civilian, which is what I did. I got accepted to medical school, and then my father was in the military. He was in the Air Force. And so he suggested I get a scholarship because, as you may know, medical school is very expensive and we didn't have the means to pay for it. So one option is to just get loans like everyone else and just to struggle through it. And another option is to apply for a military scholarship. So I
Mm.
applied for the Air Force scholarship and I was granted. It's a very difficult scholarship to get because they pay for all of medical school. They give you books and tuition, a little stipend, and then every summer you do an active duty rotation. And in that rotation, you're a second lieutenant while you're in medical school. And then when you graduate from medical school, you're commissioned to a captain and you enter the
Mm.
military on active duty service. So that's what I did. That's called the Health Professions Scholarship Program,
Mm.
HPSB. And so that program, and every branch, Army, Navy, and the Air Force all have a version of that scholarship. And then when you get out, then you owe the amount of time that they paid for school back to the military. So for me, 4 years of medical school meant 4 years of commitment. And then your training starts. So at that point, some people still continue to train in civilian programs. So they may say, well, I'm finished with medical school now. Now I want to go to a residency, a civilian residency. And so then they can apply. But in the military gets to decide. They get to decide everything. They get to decide if you get to do a residency or not and what specialty they allow. They usually will limit the number of specialty slots they allow for each different specialty. And so when I was training, we didn't have military residency programs for orthopedics other than the one Air Force program. We had only one program in the whole Air Force, but there was no way to get into that program out of medical school. You had to go out in the field and be a doctor, like a flight surgeon or a general medical doctor. And a flight surgeon is basically a general medical doctor for pilots and their families. And you can treat special forces and you get to fly, and that's a cool job. So most of the people that went into the military Air Force orthopedic residency would do that. And because I wanted to be an orthopedic surgeon, my goal was to do an orthopedic residency, obviously. So I I went through the civilian process, but the year that I applied, they said no one's going to be allowed to apply to a civilian orthopedic residency this year. So we were all kind of pulled in, kind of forced in, honestly, into the Air Force. And so we had to do internships in the military. And so I did that. at Wilford Hall. And I worked really hard and went to the morning rounds every day. And I just did a lot more. I did my normal residency rotation, my internship, and I had to rotate on all the different specialties. But every morning I would go to the orthopedic rounds. And when they had call, I would pull call when they had to do their board exams. And I did a lot of extra things to make myself, known in the department. And then when I applied, I got into that program, which was very difficult at the time because there were only 4 people in the country who wanted to do orthopedic residency who would get selected for that program. So it was the hardest thing to get into as far as orthopedics goes in the Air Force at the time. And then when I did my training all in the military. So I did it at Wilford Hall. Wilford Hall has changed a lot since then. My training was between 1996 and 19, oh, sorry, yeah, no, 1997, sorry, and
Okay.
2003. Yeah. So that training, it takes time. So I was a flight surgeon for 2 years because when you get accepted, even if you get accepted immediately, there's a 2-year wait. So I did a two
Okay.
year deferment. I waited for my time and I spent 2 years as a flight surgeon and then I entered the military. So my experience is a little bit different. While I was a flight surgeon, I moonlit downtown and I worked at different family practice clinics and I learned a lot about general medicine, but both in the
Mhm.
military and then outside practicing and moonlighting. And then I did my Air Force training. And when I was done with my Air Force residency, then I decided I wanted to be a spine surgeon. And
Mhm.
I applied for that. You have to get approved for that. They have to say, we need a spine surgeon or we don't. And there are years where they say, we don't need any spine surgeons. We only want hand surgeons or joint surgeons. And that
Okay.
applies to every single specialty.
Mhm.
So that's the process of getting in. So then I applied, I got accepted, and they didn't have a fellowship in spine surgery in the Air Force or any fellowships for orthopedics for that matter. So
Mhm.
all of us would go civilian training. So then I chose to go to the Mayo Clinic. That was my first choice. My other top choice was the Hospital for Special Surgery, both the top 2 programs for
Mhm.
what I wanted to do in the country. And I was accepted to both. And then for personal reasons, I felt more drawn to the Mayo Clinic people. And so I went to the Mayo Clinic, and that's where I did my spine training. And then I had to come back and pay back my time. So all of that incurs more time, more commitment to the
Mhm.
military. Every leg of training that you are given, it's hard to get it, number one. And when you do, then you have to pay more time back. So my 4 years went to 8 years. So by the
Mhm.
time I was done with all of my active duty commitment, it was 14 years.
Wow. So when you work in the like operating room and when you work on the like war zone, okay, what is the different mindset at that time you had? Because in the operating room that you would be the very silence, the room is very silence. You have your own time. But in the war zone, you don't have any enough time. You don't have any kind of a clean air or anything. So what's the different mindset at that time you had?
Well, the environment is totally different. The mindset
Yeah.
has to be different because everything that we do in a war zone is life-saving measures. We're trying to stabilize and temporize. We're trying to get patients off the table and out of the hospital to a more clean environment so that they can get care that eventually will be the ultimate treatment that they need. And so we're not there to do a definitive fixation, and it's all rapid trauma. Trauma surgery in that scenario is multi-trauma. When we were there, it was really bad, especially in 2006. We would get 45 traumas at one time, and we had probably a team of maybe 10 surgeons and all the nurses and the surgical technicians and everybody that supports that. And then, of course, there was an ER department of doctors, and everybody's working fast and furiously to try to stabilize the patients and when they needed surgery to get them to the OR. And we would just descend on those patients as teams. So it's very different. There's the general surgeons are working on the stomach trauma, the exposed
Mm.
guts. We're fixing the arms, and we're doing everything simultaneously to stop the bleeding and to try to save the patient's life. And so that it's chaotic, it's hectic, it's fast, it's life-saving, it's definitive. You don't have time to waffle or get nervous or freak out. You have to just dive in, you jump in as a team, and if you're in sync, you can really do amazing things. So very different. In the States, when we're back home and we're doing elective surgery, we walk into the operating room, we have a scheduled time, it's casual, we listen to music
Exactly.
we
Yeah.
like. We have planned out the surgery. I've measured every bone, and when I put a screw in the bone, I measure the width and the depth of every bone at every level I do surgery on. So it's very precise. I've looked at all the images, I've read. I have
Mm.
MRIs, I have X-rays that I look at flexion extension to see if there's instability. I look at it sometimes a CT scan. This is what I use to measure the bones. We have much better equipment. We have better supplies. Our surgery equipment is there's trays and trays and trays on the back table that are sterilized equipment of every size, a screw, every size rod. literally everything we need, bone graft, everything we need to do
Hmm.
surgery in a very careful and methodical way. Whereas at war, you have hodgepodge equipment, the equipment usually incomplete sets, improper screws. We don't have all the stuff we need. There's flies on fly paper literally all over the wall. When we were there, we were in tents. There was water on the ground when it rained. It was we were in the OR with water, incoming. We'd get the notice that bombs were coming within 1,000 feet, and we have to keep doing surgery. Our mindset can't be panic. You can't. You have to focus. If your
Hmm.
tent gets hit, you get hit. But you're going to keep working, and so it's
Wow.
very different, very different.
Okay. So you're treated like elite soldiers, right? So when they blow a disc, do they heal faster because of their mindset?
I think mindset has a huge impact on healing. And whether
Mhm.
that's an athlete or someone who's just mentally tough
Mm.
and somebody who's physically tough, I think they recover faster for sure because they push themselves. But there's a fine line between being too motivated and being not
Yeah,
motivated. And I think that when people are physically fit coming into surgery or physically determined, they're going to make sure if they're compliant, they're going to make sure they follow all the instructions, right? The postoperative instructions are almost as important as the surgery itself and making sure
mm,
that the surgery is a success. So if you have someone who's physically fit and their muscles can recover faster, that part of it is going to help them recover. But at the same time, when people are physically fit and they have nice toned muscles, when you do surgery around that muscle, when you move the muscle away from the spine, when you do surgery on their leg muscles, anytime you're moving the muscle or working around the muscle is much stronger. So when it contracts, it actually causes more discomfort. They have more pain from muscle
exactly.
spasm,
Mm.
but they recover and they tolerate it better when they have that. The elite soldier mindset is a whole different mindset. It's not like
Yeah,
it's
exactly.
beyond the competitive athlete mindset. The special forces people are a whole different breed of toughness, and a lot of it is mental. They're not
Mm,
necessarily, a lot of them aren't the biggest, most muscular, or even the strongest people. They're just mentally the strongest. And that's how they get through that training. And so when you have someone like that, as long as the problem with it is, you can imagine, as long as they're not so motivated that they ignore the instructions or the restrictions, they can have an amazing result. But if
mm.
they are so motivated, they don't realize that they're doing more than they should, they can actually make the surgery fail. So, like I said, there's a plus minus to that mindset.
So was it happen in your life that suppose if you tell that particular patient that you will be the paralyzed in the future, but suddenly after some time that he start walking normally?
Well, I've had a lot of people that have had injuries where the spine has broken and then the bone collapses into the spinal canal, but because the bone looks like cylinders and then behind it is the
Correct.
spinal canal. And so when the bone breaks, sometimes it'll break and push back into the spinal cord.
Mm,
And if that happens, then you can lose function. There are people that have spinal cord compression and they've had neurologic problems. They have deficits that improve when you take the pressure off the spinal cord. And then there are some that don't. You can free the spinal cord of pressure sometimes, and sometimes it totally recovers, and sometimes it stays the same, and sometimes it actually gets worse. And so those things, because when you remove the pressure, blood flow comes, inflammation, there's a lot of things that can happen that can temporarily make things a little worse. And sometimes the trauma is too far for it to reverse. So the spinal cord and the central nervous system is not that forgiving. When it's traumatized, when there's a damaged spinal cord, if scar forms in the spinal cord, that function never comes back. And if you can get to it soon enough, take the pressure off soon enough, or if enough damage hasn't happened at the initial accident, you might be able to get them to walk again. And I've had several people who have been shot, bullet in the spinal canal. I removed the bullet. They were able to walk again. People that were in a plane crash and they were they were unable to walk, and I was able to decompress the spinal cord and they were able to walk again. But I also have people that had spinal cord damage that all I could do was stabilize their spine and stop the spine from shifting because it was broken or unstable. But I couldn't reverse the damage to the spinal cord because sometimes it's too damaged.
wow. So when you do this amazing job, okay, you save multiple lives. That why that federal agencies and the business was behind you.
Well, I think when you're in medicine and you are entrepreneurial, and in
Mm,
other words, if you have your own practice or if you invest in businesses that are connected to medicine, I think you open yourself up to risk. And
mm,
it shouldn't be that way, but medicine is one of the most highly scrutinized professions. And I think the theory behind the laws that stop you from being entrepreneurial makes sense. A lot of what you don't want is a bunch of doctors out there trying to make money and hurting patients doing things that are unnecessary, right? And no matter what your profession is, there's always going to be people that do that, right? So there have to be rules in place that stop that from happening. The problem is it's gone too far the other way.
mm,
And what the business side of medicine has done, the insurance companies and the hospitals, is they've taken control of medicine
mm,
to a point where doctors no longer have the authority to make the final call. And that's the problem. And so because they want to keep the profit on their side of the equation, they don't want doctors to be able to be businessmen. They want to take the business because the profit in medicine is on the business side, not on the medical side. On the medical side, it's about 8% of the profit. 92% of the profit is on the business side. So you can
mm,
understand why lobbyists and people that work for the insurance companies, the people that work for hospitals are basically lobbying Congress to pass laws that make it unethical, even though it's not really even, unethical for doctors to be involved in the business side of medicine. So they have restrictions and standards, and they pass it under the guise of protecting patients. Meanwhile, nobody's really policing them, right? And
mm,
they're the ones that are in complete control and deciding yes or no when you get an MRI, yes or no what type of surgery to have. And all they have to do is hire some doctor with an MD after the name. They don't have to be a specialist. They don't have
mm,
to be a surgeon, but they could deny whatever they want because they're doctors and they're supposedly peers. And so what happens is when doctors try to be entrepreneurial, it opens them up to scrutiny, right?
mm,
And the problem is because we are not able to be the primary, for example, the Stark law, the anti-kickback law, they limit
mm,
doctors to 40%, right? And that's all the doctors involved in an investment. And you can't refer to yourself and all these other rules, right? So even when you're super careful, the business people on the 60% side, if you're in a business partnership, like if you decide, oh, I'm going to buy into this hospital because it's a really good hospital and I like what they're doing, I'm going to buy in. And that's what happened to me is I bought into a hospital and you're 40%. So there's 40 doctors where all of you are the 40% combined. It's not 40% each, it's 40% total. Well, that means you're always the minority owner in a business arrangement in medicine. So what
that's
happens
true.
to a lot of doctors is they get sucked into these business arrangements thinking, hey, I'm going to buy into this MRI or I'm going to buy into this hospital and it's going to be really good because I'll be able to help make decisions. I'll be able to help provide better care. I'll be able to decide who we hire, who we don't keep, those things that are important to making sure that the business that you're part of is run properly and that you're thinking of patient outcomes and not income, right? But when you do that, you think you have control, but you're the 40%. So you don't really have a vote at all. Your vote doesn't matter because the 60% side, as dictated by law, is always the non-physicians. And what are they going to do? They're going to decide what's best for their dollar, the bottom line, which is money. And so doctors are stuck in this arrangement where they don't have the power, they don't have the control. And so the business people make the decisions. And if they're unethical, you're stuck with them, right? And now
Mm,
you all get scrutinized or your business investment fails. And all of those things happen all the time. And so that's kind of what happened to me. It's not that the system is like looking to go after people specifically, but there are laws that were passed in 2013 where doctors can't own hospitals. That was an Obama law, part of the Affordable Care Act, which
mhm,
obviously I disagree with. And then there are all these other rules where the businessmen who have no knowledge, no care, no responsibility for patient outcomes are in control. And so they want to keep it. And so what they've done is they've made it illegal basically for doctors to think outside the box and to benefit from the business side of medicine. And they're not going to say what the real goal is. The real goal is money, but they always try to sell it by saying, oh, well, we want to make sure that it's ethical. There's no unethical arrangements or treatments that are unnecessary. And honestly, it's a little bit of a farce. And so what has happened is doctors who are entrepreneurial, who have their own practice, have
mm,
found that because they don't have control of how much they're paid, we're all paid based on a table. It's codes that are dictated by the CMS, the
mm,
Medicare services, and then also the insurance companies, the rates that they provide. Those dictate what we get paid. So it's the only business that I know of where the person paying the bill dictates what the bill is worth. It's like if you go to a car dealership and you say, hey, I want to buy that car, and they
mm,
say it's $100,000, and you say, no, here's $40,000, and everybody agrees, right? This is what you get. That's what's
mm,
happened in medicine. The people that are the consumers, which I'm not talking about patients, I'm talking about insurance companies who dictate what the rates are. It's actually crazy. How is that not a conflict of interest where the people paying for your services dictate what they
mm,
pay you? That's crazy. But that's what's happened in medicine. And it's just whittled down further and further and further over the years. So that if you compare what we make today versus what we made in the 90s, we make 300% less. And so doctors' practices are closing left and right. There are very
Mm,
few private practices left. Almost all doctors are now employed. And if you look at the number of doctors employed now, it's 80%. 80% of doctors are employed by a hospital.
mm,
And that's where the big problem in medicine costs come, because medicine is expensive and everybody wants to get the cost of medicine down. Well, the only way to do that is to give the control back to the doctors who care about the patients. They know the patients, they have a responsibility to the patients. There are multiple layers of risk for doctors doing things that are unethical, both locally and then nationally, that legally. And there's so many things that can happen if you're an unethical doctor, that
mm.
you're at much more risk of getting in trouble or scrutinized than the business people who are actually committing things that are unethical or
So if I say in your words, the business peoples are forcing you, or they are giving the target you, that you should do this much of or this many of surgeries in a whole year. Are they giving target you?
No, I don't think they care about the number. I mean, the business people, I would say, are the insurance companies. Their goal is for you to do no
Mm,
surgery, right? I mean,
mm,
every time a patient uses their insurance, they're taking profit away from the insurance. And
mm,
that's why I think they don't care if they don't want you to do surgery. They want you to
mm,
do no surgery. They want to deny surgery. They want to deny expensive treatments. They call everything experimental, even things that are proven to be successful. They just label things experimental that don't have like a universal application, just
mm,
because that allows them to deny care, to deny treatment. And then what's happening even worse than that is now, even when you get surgeries authorized or treatments authorized, now they're going back after it's done. Imagine
mm,
this. Imagine if you went to work, you had a job, somebody gave you a proposal, you did the job, you say, here's my estimate, this is what it's going to cost for me to do this for you. And they say, okay, no problem. I agree. They agree to pay you. You have a contract, you have an agreement.
mm.
And then after you do it, then they say, actually, I decided I don't want to pay you anymore. That's what they do all the time. The insurance
Wow.
companies do that all the time. And they'll actually, because they have access to your bank account, they'll go in and they'll take the money out from a future patient, a future payment. And you don't even have any say. There's no arbitration, there's no legal, means for you. You really have to hire a lawyer. It's really, really gotten absurd. And so you can imagine in private practice, if you are having those issues on a repetitive basis, how you can suffer financially, and eventually your practice will fail. And every
Mm,
year, everybody who works for a doctor, their salary goes up. Every year, doctor salaries come down. So the medical assistants, the secretaries, the physical therapists, the physician assistants, the
mm,
the nurse practitioner, everybody wants more money, right? All the administrative
mm.
people, your practice manager, everybody wants a higher salary every year. They want bonuses. Meanwhile, our income keeps coming down because the reimbursements from the insurance companies keep getting squeezed tighter and tighter.
Correct.
And
Okay.
so it's a really difficult equation.
So in your book, The Cutthroat, okay, your book says that doctors turn on each other. Do the hospital system use anonymous tips to trigger investigation and eliminate independent surgeon?
Oh, for sure. I've seen it happen. It has never happened to me, luckily. I mean, but
Mm,
but I have several friends who have been in big hospital systems who a peer that worked for the hospital system would report something about their character or their treatment or whatever, and they would lose their privileges, or they would go to a
mm,
peer review, and it was really tough for them
mm,
politically. And so you'll see a lot of doctors, that are not part of a system try to avoid hospitals that are systems, because those things politically can happen, and doctors do turn on each other because you're competition. Why would they want you coming in and bringing other, cases to the hospital when you're competing with them? So if they can eliminate you as competition in the community, then they can get ahead, right? So, and there are mercenary doctors, that are merciless as well. Just they're business people too sometimes, and so that happens, and we're all fighting for crumbs, So everybody's like a lot more on edge, and they're attacking each other online. They're attacking each other verbally, and there's a lot of animosity amongst physicians. There's a lot more competition. It's not as collegial as it once was, for sure. And there's still collegial organizations. I'm part of my cosmetic surgery organization, the American Academy of Cosmetic Surgery is very collegial, but a lot of the other specialty boards are not at all. And the doctors, there's a lot of infighting and competition and, back talking and, just a little bit of sabotage. So the system has made doctors more adversarial to one another.
So why that peoples are paying insurance so much? Okay, but still they are paying out of pocket so much of money. Do you feel that government and the insurance companies are running that business?
Well, I think there's definitely some government. I mean, there's government involvement for sure. And when, like I said, I mean, this is not to attack, the Affordable Care Act, but what happened with the Affordable Care Act is when they forced the insurance companies to cover everybody in
Hmm.
America, what it did was it forced them to cover people that were higher risk, that were more likely to use their services, that were more likely to get treatment, and it cost them more money. So what do you think the insurance companies did? They didn't just cover them and lose money. No, they raised the premiums on everyone else so that they can make
Exactly.
up for the loss, right? So that's what
Hmm.
happens is, the idea, there's a lot of things in theory that sound great. Everybody should have insurance. All right, I
Hmm.
agree with you. But where's the money come from? If you raise the premiums, these are real numbers. Some of the insurance companies have made 1,700% more, 1,700% more than they did before the Affordable Care Act, because all they
Wow.
did was raise premiums. So there's
Hmm.
more people and they're raising premiums, right? So, and then you
Hmm.
get a marketplace, which is one of those Affordable Care Act insurances. They're available, so you don't have to be connected to a company. You can just go get insurance. The problem is when we advise our patients to do that and they go on the marketplace and they get one of those insurance plans, they cost a lot of money
Hmm.
and they provide very little care. They get
Hmm.
denied all the time. We have to spend 10 hours on every like surgery we're trying to get approved on the phone, trying to convince them to approve a surgery that meets all the criteria for surgery. And so, it sounds good in practice, but the money has to come from somewhere. And what they're doing is they're just raising premiums on average everyday Americans. And so we're paying 3 times more than we used to for insurance, and we're getting less care now than ever. And doctors are making less money. And so the only people winning again is on the business side of medicine. And so until that's changed, and that's the main reason I wrote the book. It wasn't really to gripe about my personal issues. It was just to basically create an expose and to say, look, here's what's happening to an average everyday surgeon, someone
Hmm.
who is thinking, of course, outside the box, but doing it within the realm of ethics and
Hmm.
and within the law. And because everything that I ever did from the day that I started practicing was done under consultation with a healthcare attorney. I never did
Hmm.
any businesses ever without a healthcare attorney reading and vetting and signing off on everything I did. And that's why, even though I was investigated, nothing ever happened because I followed the rule. But being investigated is too much already. And when that
Hmm.
happens, it's very traumatic. And so the system is really geared towards making doctors stay in their little lane and just practice and become an employee. And then I control your billings, I control your patients, and I make all the money if you're on the business side. And so doctors are the pawns of the business world. And
Wow.
that's, I think, what's happening is we're seeing poorer results at higher cost. And that's
Hmm.
not the equation we want to see. We want to see lower cost with better outcomes, right? That's what
Hmm.
everybody wants to see. I think all the doctors involved in taking care of patients want to see better outcomes and they want to see it at a lower cost to patients. And doctors aren't the problem. Doctors' income's going down, it's not going up. It's not the doctors that are costing Americans more money. It's the system. And the system has to be revamped completely. The profit has to be rerouted. It has to be taken, the control has to be given back to doctors with scrutiny and oversight, of course, because doctors are at risk too of being
So you
unethical.
agree, so you agree that don't doctors don't have a control to take a decision about that one. So you only take a decision about that the patients will have the surgery or not. The rest the insurance company will
No,
do.
no one should ever be able to tell a doctor and a patient that the treatment their doctor recommends is disapproved. That should
Hmm.
never happen. The scenario where a doctor and a patient meet, the doctor is credentialed with the insurance carrier. The
Hmm.
patient has insurance, and they say, "Okay, you have this problem. Your spine is unstable. I think your spine needs to be stabilized." If that doctor has the credentials and they have the training and the
Hmm.
patient trusts them, there should never be another doctor who comes in, whether they work for the insurance companies or not, who can say, "Sorry, you can't have surgery." And it's even worse than that because there's the first line of denial comes from a non-physician. It's not even a doctor most of the time, it's a nurse. not to take away from nurses. They're amazing at being nurses, but they're not surgeons and they're not doctors. And so, again, you have to kind of stay in your lane and do what you're trained to do. And nurses aren't really equipped with the education to say whether a surgery is approved or not. You're looking at a recipe, a cookbook. I mean,
mm,
you
mm.
can't treat patients that way. And so that system is flawed in so many ways. But yeah, that's one of the other problems.
So you agree that that could be a corrupt surgeons who are really working for the insurance companies only.
Oh yeah, of course. And I don't know if they're corrupt, but they're definitely just trying to make money, right? A lot of times what
Mm,
happens is when doctors retire, when surgeons retire, their retirement plan is to be a medical reviewer, or they
mm,
become the medical director of an insurance company. And their job is to approve or deny surgery. I actually did medical reviews for a short time,
mm,
but I approved everything that sounded safe, even if it wasn't exactly what I would have done, because it wasn't my decision. It wasn't my patient. I wasn't taking the risk of the care. And the
mm,
company that I did those approvals for, eventually, they were told to stop using me by the insurance companies because I didn't deny enough. And so what happens is these doctors are in this program where they deny, they keep getting patients, right? We need you, where they keep sending reviews to them. If they approve, they probably stop sending. And so what happens is the goal is to get them to deny. And even when the science is very clear and that you meet all the indications for surgery, even using their criteria, sometimes they'll deny it, even then. And so it's a flawed system. And then, like I said earlier, a lot of the doctors don't even have the credentials to make a decision. They can't even do what they're denying. So they can't even practice in that state. I mean, why? How are they able to deny? How are they able to deny a surgery that they can't perform themselves? They don't know how to do that procedure. It's like me telling somebody who's a gynecologist whether or not they can do a gynecologic surgery. It wouldn't be appropriate. And just like it
mm.
wouldn't be appropriate for a gynecologist to tell me when to do a spine surgery. But that's what happens with the peer review process. And sometimes they're not even surgeons. I've had pediatricians, I've had family practice, I've had ER doctors, I've had I've had internal medicine doctors deny treatments that we recommend.
So what does it cost to you mentally to fight your reputations while watching the colleagues already given up?
Well, for me, it's worth a fight. I think the primary goal of any surgeon is to make sure they're making a difference, that they're taking care of people. Surgery and medicine in general is a calling. It's a profession that puts a big toll on you, even when you're not fighting the system as heavily as we are now.
Mm,
And so even if your battle is that you're carrying the weight of someone's health in your hands, on your mind, what you do or don't do can hurt people, it can help people. There can be tremendous reward, but there's also tremendous risk in what we do. So that battle is there no matter what happens. And for me, it's just become sort of commonplace for us to fight the system, to not give in
mm,
when they try to deny surgery, to keep pushing for the surgeries to be approved, to make sure patients meet criteria, to make sure, number one, that patients need surgery, when we take them to surgery. We also do a lot of non-operative treatment because most patients that come see me don't actually need surgery. Most of them
mm.
need non-operative treatment. So we have physical therapy, we have pain management. In my practice, we do a lot of different things. And I have two different locations, but one in Houston and one in San Antonio. In San Antonio, we basically have everything in one place. In Houston, I don't have pain management, but I do have therapy. So we do the conservative treatment. And then when people need something that we don't provide, we refer them out to people we trust. And when those things fail is the only time we talk about surgery. But I think that battle will never end. What I want to see for the sake of patients is a time where doctors who actually are the ones on the hook for the care and who have the training and the know-how to make the right decisions are the ones actually making the decisions unobstructed by the business and the people involved in the business side.
So that's the Mayo Clinic is working on right now.
Well, I think Mayo does a great job, but it's a big facility and you have to be an employed physician to work there. And not everybody wants to live in Rochester, Minnesota, you know what I mean? Or Boston, Massachusetts, or you know what I
Mm,
mean? The country is full of places that need well-trained, conscientious doctors. And
mm,
so they're not going to always be affiliated with a hospital. In fact, the majority of surgeons shouldn't be. I think that those big academic facilities are different. There is a corporate practice of medicine
mm.
that doctrine inhibits non-surgeons from employing surgeons, but the hospitals have gotten around that with a loophole and they employ surgeons. And so what happens is when a surgeon works for a hospital, the reason that healthcare costs go up
Mm.
is that hospital bills the services for that physician at a much higher rate than if you were to go see a physician not affiliated with a hospital. It's much higher, 75% higher or something like that. It's very high. And so when the more doctors are working for a hospital, the medicine costs, the care and delivery of medicine
Correct.
keeps.
Yeah.
Yeah. And so if you ever want to get it back, part of the solution is to get people back in a private practice and to make it lucrative enough for doctors and autonomous enough for doctors to practice on their own without being obstructed by the business side and the scrutiny and the risk and all the things we worry about. I mean, we should be able to invest in businesses without worrying. We should be able to control hospitals without worrying, own
Mm,
hospitals without worrying, bill at a rate that is reasonable, that the societies, each specialty society should dictate what their rates are, not insurance companies. There's
mm,
little things like that should happen. And with the new administration changes, with ours, Dr. Oz is at the head, Dr. Makari, and there's a lot of people that are actually practicing physicians in their past who
mm.
are in the system now. And so maybe things will start going back the other way towards control for doctors and better care for patients.
So if a patient doesn't have any insurance, will the Mayo Clinic will treat them?
If somebody, so there is a rule, there's rules in America where if somebody has an emergency problem and
Hmm,
they need surgery, no ER can turn you away unless they are inadequate to provide the care you need, right? So that's called the COBRA law. So you have to take
hmm,
patients in who need emergent care. Now, for elective care, it's different. For elective care, you either have to have Medicaid or you have to have Medicare or you have to have some kind of plan.
hmm,
So if you don't have an insurance plan, you can pay out of pocket. There's health savings plans. There's a lot of different things. And there are some changes. President Trump recently said that he's going to start giving money, subsidizing patients instead of
hmm,
insurance companies. The,
hmm,
the insurance companies are heavily subsidized by the government. The government gives a lot of money to insurance companies to provide care. And a lot of the Medicare treatment that's provided by insurance companies is actually covered financially by the government. And so if that money is basically rerouted to patients and they create health savings plans or
hmm,
health plans for patients that they can basically buy into and have the money in their own pockets, now all of a sudden there's going to be buying power, and then competition will drop prices and better care will start to come out of that. So I think that that's actually a good idea. I think that's one of the many things that needs to happen is that those subsidies, that extra money given to the insurance companies need to be rerouted to the patients that need
hmm.
care. And I think that'll help. That's one thing that will help.
Okay. Okay. Now let's talk about the spine. So I have a special questions related to the scoliosis and the kyphosis. Okay.
Okay.
The kids are getting massive spine curve. Is that a genetic or something else like a diet or activity?
So I think scoliosis and kyphosis primarily are genetic conditions, right? If you have
Okay.
Scheuermann's kyphosis or scoliosis, a lot of that is genetic. Now, can it be worsened by posture? Yeah, you can get a thing called postural
Mm,
kyphosis. If you slouch when you sit, if you carry a heavy backpack, if you don't exercise, if you're on your phone or you're on your computer all the time and you're hunched forward, the
mm,
muscles in the front can start to get contracted and the muscles in the back can start to get lax. And so your spine will deviate forward. That happens to the neck. That
mm,
happens to the mid back often. It even happens to the lower back because a lot of us have jobs where we're sitting down, that muscular imbalance gets worse. And
mm,
so I think we can improve the results of this sedentary life and this data filled life with, phones and computers by making sure that our kids are staying active, physically fit. They're stretching, they're working on flexibility in the front, they're stretching their chest, they're exercising, they're engaging in sports, they're working on their muscular strength in the back and just balancing their body out. So I think that whether you're somebody who has a sedentary job or not, or you're a kid in class or you're on your phone, you need to make sure that your life is balanced with activity, stretching, building, weightlifting, athletics, and that will help it. But the majority of people that come with scoliosis and kyphosis have a genetic condition. Or in time, what happens is if you have a mild curve when you're young, in time with aging, the discs are symmetrical when you're no, when you're young. But as you get older, the discs can, especially when you have a curve, they can wear out preferentially on one side or the other. That happens to our joints too. Our knee is a good example of that. And when
okay.
those joints wear out unevenly, if there is a small curve, the small curve can become a big curve. And when
Mm,
arthritic changes set in, that can actually make the spine more stiff and that can make spinal pain more prevalent. And when
mm,
you're osteoporotic, when your bone becomes soft with age, the bones can collapse. So you have a cylinder that can turn into a triangle. And so the spine goes from, a nice natural position to this collapse because the bones
mm,
break. So there are things that worsen with time, with position. Most of the postural changes in young people are things you
mm,
can reverse with therapy and with training. And the things that are more actually the skeletal system becoming abnormally aligned, a lot
mm.
of that's from age or genetic.
Okay. So when it has a more curve like that one, okay.
Mhm.
So does it really need a surgery, or that could be the any without surgery? Is there any possibility that it can be cured, like a braces or anything?
Yeah, so and when kids are young, that's when it's vital to know, right? If you have a kid who has a curve, you want to see it before they go through their growth spurt. For girls, the growth spurt happens between 10 and 15 years old, maybe 16. For
Okay.
boys, the growth spurt happens between 12 and 18, 12 and 17. And
Mm,
it's at that vital time, that growth spurt. If you get to them and you identify their curve before that spurt, you can actually halt the progression of the scoliosis a lot of times.
mm,
So that's why they implemented school screening. You look at kids' backs, you have them bend forward, you feel the spine. Because with scoliosis, there isn't just a curve, there's also a rotation. So when someone bends forward and they rotate, you can see one side of their back is
mm,
kind of punched, like it kind of curves. The rib cage is up like this on one side or up like this on one side. So when they bend forward, you can see it. And when you look at their spine, you can feel their shoulders from the back or their pelvis from the
yeah,
back.
they
And
are
so
mismatched.
uneven.
Mm,
Yeah. So if you're a parent, that's an easy way to identify it. You feel the shoulders, you feel the pelvis, you look at their back, have them put their hands together like they're praying and lean forward and look at their back and see if their back looks like a hump on one side by their
mm,
shoulder blade. And that tells you that they have scoliosis. If it's
mm,
visible standing there and it's real big, then they probably need to see somebody. If it's mild, they probably should see somebody also. But what you don't want is you don't want to wait so long, because if the curve is 30 degrees or less and they haven't hit their growth spurt, you can brace it and
mm.
you can stop it from progressing to 40 or 50 or 60 degrees. And sometimes it's too big. If it's 50 degrees or bigger, they usually need surgery. So,
Okay.
those are all the things that we think about when it comes to kids. The same thing applies to adults, the same criteria, of course. The only difference is when someone has a spine that's unstable from arthritis or from age or from trauma, and right above where they're unstable, they're curved.
Mm,
We usually, if you've trained to do deformity, you don't usually leave a curve
mm,
right above an unstable segment. If you fuse that unstable segment, you probably want to include the curve, because what will happen is the stress will transfer to that unstable segment and that curve will progress. And so
mm.
if the curve is significant, a lot of times we include it so that we can get to what we call a neutral bone in the back that's not curved or tilted. And that's how you try to stop the progression of scoliosis from happening.
Right. Agree. So everyone stares at the screen right now. Okay. Are we creating a permanent hunches, or what does that do the breathing and heart function?
Well, I think that if you have severe kyphosis, it can definitely impact your ability to breathe well, your inhalation and exhalation, right? Become compressed. If you have a compressed thoracic cavity,
Mm,
the more progressive your curve is, the more severe your scoliosis is, the more it can affect the ability of your lungs to expand. So when you have that, either progressive or severe kyphosis or severe scoliosis, it can have an impact on your lungs and your
mm,
lung capacity. If it's inhibited, it can ultimately lead to heart issues, right? So I don't think that those things are permanent when they're from devices. I think that when you're on your computer, your phone a lot, I think most of that is muscular. It's mostly soft tissue, and those things
correct.
can be reversed with the right therapy and with the right exercise and with the right stretching.
Mm,
But when you have a severe structural curve, it's from the bone or the joints or the ligaments. If those things are inhibited and they're not straight, then sometimes that has to be addressed surgically. But some of it can be reversed with therapy.
mm. So if a I mean, if a parent notices their kid looks crooked, okay, how much time do they have to fix without surgery?
Well, if you have a kid with scoliosis, you should go see a pediatric orthopedic surgeon immediately when you notice it. That way
Mm,
they can look at it, they can take x-rays of it, they can measure it, they can see if the curve is severe or mild, if it's something that should be braced or watched or treated surgically. So I think for me, even as a doctor, like I said, I've been a primary care doctor, I've been an
mm,
orthopedic surgeon, I'm a spine surgeon, I'm a cosmetic surgeon. If I ever have a question about my kid's health, I don't just
mm,
wait it out. I actually have a high threshold. I mean, I have a low threshold for going to have a specialist take a look. So you
mm,
should too. If your kid has a big scoliosis or a small scoliosis, either way, have a pediatric orthopedic surgeon take a look, make a measurement, and decide if it's something they need treatment for or something they can watch. Sometimes they'll just observe it and they'll see if it's 10 degrees, 15 degrees. If it's below 20 degrees, they'll probably observe it. But if they're going to hit their growth spurt in that age range that we talked about earlier, between basically 10 and 18, then you want to make sure that they're treated and they're watched. And we'll sometimes get x-rays every 6 months
Mm.
to make sure that we're not missing a progression of a curve and then making it so severe now we waited too long and now it's a surgical problem. So that's something that I would do. I'd say if you see a curve in your patient, in your son or daughter's back, bring them to a
Mm.
pediatric.
All right. Okay. Now, everyone says you are hybrid surgeons, that you do the orthopedic and the cosmetic surgery too. How does it knowing the spine change? How do you do the liposuction?
Yeah, so the way I became a cosmetic surgeon was interesting. I've always been artistic. I had a comic book. I actually my own comic book. I've drawn my whole life. I like when I
Mm.
would draw my notes in orthopedics, I always draw the hand and I like to draw, right? I'm an artist. And so part of that artistic part of my mindset has always been unfulfilled in medicine. I because what I do is engineering. Like spine surgery is engineering, orthopedics is engineering, it's biomechanical engineering of the body. And so over the years, a lot of my spine surgeries, I
Mm.
perform the front of the spine surgery by removing the disc through the front. I go around the abdomen, and then we go to the back and we put in screws. Those
Mm.
surgeries, in my opinion, have the best success rate. So it's an anterior and a posterior approach. And so when I do that, over the years, I've been a spine surgeon for 22 years. I've had multiple patients, both men and women, say to me, "Hey, while you're in there, why don't you take out a little bit of this or take out," and it was always kind of in jest. It was a little bit of a joke. And so I would always laugh it off. But I started to really think about it as insurance companies started getting tighter on the reimbursements and medicine started to become more difficult to make a profit in and to do well with. I started getting worried. What was happening to medicine? Was it going to continue to decline to the point that I wouldn't be able to provide for my family? I'd have to close my practice. I just didn't want to put myself or my family or even my employees in that position. So I decided, I was like, well, I've always been interested in cosmetic surgery. I've always been interested in the reconstructive part of orthopedic surgery, but the cosmetic side of it, I thought was really interesting. And so I started looking at training and I ended up deciding to do a cosmetic fellowship. I ended up finding the president of the American Board of Cosmetic Surgery at the time, Wilbur Haw, available to train in Texas. And I talked to him and he decided to help me train with him. And I did a 2-year fellowship under the American Academy of Cosmetic Surgery for the president of the American Board of Cosmetic Surgery. And I did 2 years of that training so that I could have the ability to do cosmetic surgery as well as an adjunct to what I do. My plan was never to stop practicing as a spine surgeon, but it was to add that to my armamentarium, my repertoire, be able to handle that too. And then if a patient came back to me and they had a big overlapping abdominal tissue, like if they had spine surgery and they needed surgery to take that extra tissue away because they lost a lot of weight or something like that, then I could handle those issues. I could do the surgery for them, get their stomach back to a more normal, position or alignment or look.
Mm.
That way
Mm.
they could be braced. There's a lot of benefits to being able to do the surgeries. And so in that 2-year fellowship, I did face surgery, I did general cosmetic surgery, and so that allows me to do whatever. And so typically what I do now is 1 day a week, I do cosmetic surgery, and then 4 days a week, it's spine.
So that's the difference that
So,
you are working on, right? Everyone that when someone is going to the cosmetic surgeries, okay, they're removing the fat,
yeah.
but you work on the muscles. So are
Yeah.
you
So,
carving the people into what they should look like?
yeah. Well, the goal of every, kind of medium or high definition liposuction procedure is to basically remove the fat over the muscle in a way that looks natural, which is a lot harder than it seems. When you're
Hmm.
taking somebody who has a lot of soft tissue over their muscle and you're trying to highlight the muscle, it's
Hmm.
not so easy, because sometimes the skin is lax and so you have to remove skin. Sometimes the skin is not lax, but there's a lot of fatty tissue that has to be removed and you have to
Hmm.
remove it and know the anatomy. So that's why for me, it made a lot of sense when I was doing my training and learning how to do liposuction.
Hmm.
I was focusing on what the muscle underlying the fat looked like because
Hmm.
to me, it made the most sense to make sure that when we remove the fat, we did it in a way that looked like the patient was naturally fit, not that they had surgery. And so if we're going to do an operation, there were people doing high definition, but sometimes they would carve the fat into bricks and it looked really unnatural. Or they would do things that looked extreme, like really small waist, really big bottom. And for me, I wanted it to look more like an athletic build, or more of a like you were working out. You can only take somebody's body so far, right?
Yeah.
The genetics are going to limit what we can do as surgeons, but you can definitely enhance the way someone looks. And if your understanding of the muscular and skeletal anatomy deep to the fat and deep to the skin is very strong because your whole focus, your whole life was on understanding the musculoskeletal system, and that's what orthopedic surgeons do, then I think the ability to know where the nerves are, where the muscles are, where everything structural is a little bit better so that when you do an operation, you not only make it more artistic, you make it more authentic, more
Mm.
natural, but you also make it safer. And so that's for me what I think the benefit of having an orthopedic spine background is, because I did a lot of surgery from the front, from the back. I did arm and leg surgery, neck surgery from the front, from the back. And so when I extrapolated that knowledge to my training in cosmetic surgery, I think it made the leap a lot easier.
Okay. Sounds so very excited. Okay. Last closing questions. If someone is sitting at home right now with a chronic back pain and they are told that they need a surgery, what are the three questions they must ask their surgeon to make sure they aren't getting screwed?
Well, I think number one, you should only be in a surgeon's office that you've highly inspected, that
Mm.
you've researched pretty deeply. Because when you're going to see a surgeon, a lot of times there are surgeons who are going to do only what they know, right? Most surgeons aren't doing surgery poorly on purpose. They don't
Mm.
have bad outcomes. Obviously, why would anyone do surgery with a bad outcome? No one in the surgical world wants to have a bad outcome. Nobody does. They all want to have good results. But not everybody's trained the same. Not everybody has the same skill. Not everybody has the same experience. And as a result, not everybody has the same back outcomes. And so when you have a different background, then your outcomes are going to be affected by that. So as a patient, your job is to be very careful about where you go, about who you see. So you should be number one, before you even get there, you should know where they did their training, where they went to medical school, where they went to residency. If it's a spine surgery or some type of specialty surgery like a joint surgery, they should have a fellowship. If they are good with patients, you should read what testimonials about that person says. And don't read one, because everybody's going to have some unreasonable patient who says something negative. But if you read hundreds of positive testimonials and 5-star ratings and 4.8 star ratings, then that person is probably a good surgeon, right? And you get to hear it from other people who have seen them. But also, when you read the testimonials, I tell everyone, don't just look at the ones that say he's great and put a 5-star. If there's long testimonials, like pages or like a long paragraph, that's way
Mm.
more important, because that means the patient really, really was invested in that surgeon. They really believed in that surgeon. They were really happy. They weren't just like doing something to fill a box.
Mm.
What did they say about the surgeon? What was that person's bedside manner? How was their care? Was there a complication? Because surgeons, no matter who you are, you're going to have complications. They're human. Patients are human, surgeons are human. So when there's a complication, did they turn the patient away? Did they ignore the patient, or did they help them work through it? What did they do? Were they available for the patient? Did they educate the patient? Did they do a good job, and did they care? Right? And all of that is in addition to where they trained, because there are people that trained at the top programs in the world that are not that good. And there are people that trained at decent programs that are very good, right? So sometimes it's the person. The program and the training is very important for sure. But not everybody who graduates from the best programs are the best surgeons. And
Yeah.
so as a patient, you should look at that first. So when you're sitting there and they say you need surgery, I would ask them, what did you see on my studies? Because most surgeons that are well trained will spend the time. Like for me, when I see my patients, I pull up the MRI and I pull up the X-ray and I pull up the CT
Mm.
scan. Here's where I see a problem, and this is what we're seeing. And I show them so they see it, they can connect to it, they can understand it. And
Mm.
I explain to them what I see. I tell them what the options are, non-operative options and surgical options. And
Mm.
amongst the surgical options, did their surgeon tell them what are the options? How many options are there? Is there only one option?
Mm.
If they say there's only one option, then I'd be a little more cautious, because usually someone who's well trained, they can work different options, right? But at the end of the day, they may say, this is my most preferred option. I think this is going to give you
Mm.
the best result, right? That most surgeons will have something they think is the best for you, and then
Mm.
something less, probably less significant, like a smaller operation, a more minimally invasive option, because it has less restrictions and less downtime. They'll think about that. And then the other option is always have the option to continue to do treatment that's conservative. You don't ever have to feel rushed or forced to
Correct.
have
Yeah.
an operation. They should, if they're
Yeah.
like pushy, 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 like they're a salesman, I'd be a little more cautious,
Yeah. Exactly.
and yeah, I mean, if they're like excited, like you're going to be on the operating room next week, I'd be a little more cautious. But I would ask them what's wrong, what they see, explain it to you, have them break it down in a way that makes sense. And if they're not willing to do that, if they're too impatient to explain a very, very big problem to you that's so big it needs surgery, then they're probably too impatient to do a careful job in the operating room. Does that make
Mm.
sense?
Yeah. Makes
So
sense.
those are the main
I
things I
totally,
ask.
totally agree. Okay. So, what do you want your legacy to be? The guy who fixed the military elite, or the guy who exposed the corruption in the American medical system?
I don't really think of my book as an effort to ever create a legacy about exposing corruption. I just think that, I mean, that's not my goal. My goal in life, honestly, my goal in life, number one, is to be a faithful servant, is
Mm,
to be a good father, a good husband, a good surgeon, a careful, conscientious person. I want my legacy to be that I cared and that I did everything I could to treat everybody I could like my family. That's what I want my legacy to be, that I made a difference in the world before I left it, and I made the world a better place with my efforts. That's what my primary legacy I hope will be. And then I lived as good a life as a person could, and I made a positive impact on the world. That's it. My faith, my family, followed by my patient. Those are the things and those three things, those aspects of my life. I hope that people that are part of that aspect of my life look at me and feel like they had everything that they could for me. Like when my patients get my care, I gave them everything I had. When my family gets my time, that I give them all my time and attention and love. And when I'm praying and faithful and thankful for the amazing blessed life that I have, even the trials that make you stronger and the tough times we all go through tough times, that I was able to get through and resilient, and I maintained my faith. I never lost my faith.
yeah. I hope all the doctors have the same legacy as you do.
Thank you.
All
Thank you.
right. Let's have a rapid fire round. This is the last one. Okay. I won't take too much time. So, only one word option, no description, no explanation. Okay. The real enemy, insurance or big pharma?
Oh, I said insurance.
Okay. The better for spine, standing desk or walking?
Probably walking.
Treatment, stem cells or scalpel?
Oh, well, not yet, but stem cells eventually.
All right. Okay. The military, discipline or trauma?
Discipline,
The body goal, aesthetic or performance?
performance.
The modern world, evolving or devolving?
Oof, both.
Okay. Dr. Steven, a surgeon or a fighter?
Surgeon.
Surgical choice, fusion or replacement?
Oh, fusion.
Fusion. Okay. The training, Mayo or military?
Mayo.
And the body philosophy, form or function?
Function.
That's it. Thank you so much, sir. It was really wonderful to show me a pictures, the movie, as you already did, and you passed through it. Thank you so
Thank
much,
you.
sir.
Thank you, Samir. Take care.